Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 134 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads: TKK, a 37-year-old male patient, presents to the ENT clinic with a past medical history significant for exercise-induced asthma, which happens to be well controlled. Type 2 diabetes mellitus, which is also well controlled. His last HbA1c was 5.5. He has a chief complaint of persistent headache, purulent nasal discharge and facial pain. He seemed to improve with ibuprofen and fluticasone nasal spray. He has worsened in the past 14 days. Some of his pertinent vital signs include a blood pressure of 140/80 mm of mercury, a respiratory rate of 25 breaths per minute, a heart rate of 120 beats per minute, and a maximum temperature of 39 degrees Celsius. Currently, he takes the following medications: salbutamol 90 microgram HFA metered dose inhaler 2 puffs 30 minutes prior to activity and PRN for wheezing and shortness of breath. Metformin 500 mg orally twice daily after breakfast and dinner. Fluticasone propionate 50 micrograms per spray. 2 sprays into each nostril twice daily. Considering TKK's presenting symptoms, which of the therapeutic options listed below would be the most appropriate for treating his ABRS? Would it be A. Cefdinir 300 mg orally twice daily for 10 days, or B. Doxycycline 100 mg orally twice daily for 7 days, or C. Coamoxiclav 500 mg of the amoxicillin component orally thrice daily for 10 days? Or would it be D. Coamoxiclav 2 grams orally twice daily for 7 days? I will give you a few seconds to choose the correct answer. And the correct answer is D. Coamoxiclav 2 grams orally twice daily for 7 days. TKK is high risk based on his comorbid conditions like diabetes mellitus and severe presentation with a maximum body temperature of 39 degrees Celsius, and therefore high-dose amoxicillin clavulanate should be utilized for management of his ABRS. The 500 mg thrice daily dose should only be used in patients not at high risk. Furthermore, the severe presentation raises concern for resistance, which could be overcome with higher dosing based on the primary mechanisms expected with Streptococcus pneumoniae as well as Haemophilus influenza. And the next question reads: your ENT consultant has been treating TKK with high-dose amoxicillin. Unfortunately, after taking a few doses according to the consultant's prescription, TKK develops a maculopapular rash and irritation on his lower trunk and returns to the ENT clinic for further advice from his consultant. So my question to you is: which of the therapeutic options listed below should the ENT consultant opt for as first-line therapy to treat his ABRS at this time? Should he a. switch to clindamycin 300 mg orally thrice daily plus cefpodoxime 200 mg orally twice daily, or b. switch to doxycycline 100 mg orally twice daily, or c. continue amoxicillin therapy with no changes? Or should he d. discontinue amoxicillin, conduct penicillin skin testing, and start ciprofloxacin 500 mg orally twice daily? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is b. switch to doxycycline 100 mg orally twice daily. In the setting of a penicillin allergy, the first-line alternative for management of ABRS is doxycycline. It would be inappropriate to continue the amoxicillin in the presence of a new developed rash, and cefpodoxime plus clindamycin regimen is recommended for pediatric patients and not adults. The other answer selections are not the best choice because the question specifically asks for the best first-line alternative agent. In this setting, while fluoroquinolones can be used, they are considered second-line alternatives. Moreover, the recent FDA labeling and black box warnings warn against use of these agents for respiratory conditions, making answer selection A an inferior treatment option. And the next question reads: 4 months later, TKK returns to the ENT clinic with persistent nasal symptoms. He informs the ENT consultant he completed the prescribed antibiotic therapy, after which his acute infection resolved. The consultant ENT surgeon performs an endoscopy-guided culture. CT imaging is done later in the day. It reveals inflammation in the paranasal sinuses. So my question to you is, which of the treatment options listed below would be the most appropriate in TKK's case now? Would it be A. start systemic corticosteroid PALS therapy in conjunction with nasal saline rinses? Or B. start moxifloxacin 400 mg orally twice daily to provide coverage for anaerobes and resistant gram-negative bacilli? Or C. provide supportive care with intranasal corticosteroid therapy? Or would it be D. repeat doxycycline therapy for 14 days for antibacterial and anti-inflammatory effects? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. provide supportive care with intranasal corticosteroid therapy. Since it is 4 months after initial treatment in which his acute infection resolved with appropriate therapy, he is now considered to have chronic sinusitis. The use of antibiotics is not associated with improved outcomes, which makes answers D and B incorrect. But use of intranasal corticosteroids can be a useful agent to aid in managing chronic sinusitis. PALS dosing of steroids has not been demonstrated to have an impact on symptoms in the setting of chronic sinusitis. And the next question reads: KNN, a 68-year-old female patient presents to your ENT clinic with a chief complaint of cough, increased production of purulent sputum and dyspnea, all of which have worsened over the last few days after her return from visiting her grandchildren. Worsening fatigue, difficulty walking from her front door to her car. She has a past medical history significant for congestive heart failure (CHF), which was diagnosed in 2016. Recent hospitalization for COPD exacerbation 2 months ago, which happens to be the 3rd time this year. Her allergies include type 1 hypersensitivity to sulfur drugs. She has a social history of 25-pack-year smoking history and is currently in a smoking cessation program. She is an environmental toxicologist. She lives at home with her husband and 2 dogs. Currently she takes vilanterol co-formulated with fluticasone 100 micrograms/25 micrograms per inhalation once daily. Tiotropium dry powder inhaler 18 micrograms per capsule for inhalation once daily. Spironolactone 25 grams orally once daily. Lisinopril 40 mg orally once daily. Moxifloxacin 400 mg orally once daily 5 days in a week. Currently she is in week 6 of PALS. Her spirometry results are as follows. An FEV1 of 1.56 liters. Her predicted value is 3.07 liters. An FVC of 2.28 liters. An FEV1 to FVC ratio equal to 68%. Respiratory rate of 35 breaths per minute. An SpO2 of 89%. A maximum temperature of 39.5 degrees Celsius. He exhibits expiratory wheezing on auscultation. A diagnosis of acute exacerbation of COPD, also known as AE-COPD, is made. So my question to you is, which of the therapies listed below would be best to initiate in KNN's case at this time for AE-COPD? Would it be A. azithromycin 250 mg orally once daily, or B. doxycycline 100 mg orally twice daily for 14 days. Or C. moxifloxacin 400 mg orally once daily for 10 days every 21 days. Or would it be D. coamoxiclav 875 mg orally twice daily for 5 days? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. coamoxiclav 875 mg orally twice daily for 5 days. Our predominant pathogens to cover in this scenario are Haemophilus influenza and Streptococcus pneumonia. Given the exacerbation history KNN presents with, therefore, amoxicillin clavulanate is the preferred first-line therapy per the GOLD guidelines. While there may be a role for moxifloxacin or azithromycin for pulse therapy to prevent exacerbations in the setting of an active exacerbation. In the setting of an active exacerbation, macrolide-based therapy is not recommended. Moxifloxacin as a fluoroquinolone would not be advocated for treatment of her AE-COPD at this time either, given the FDA-labeled warnings against use for respiratory infections as well as her previous inadequately dosed PALS therapy that may pose resistance risk to her. Therapy with coamoxiclav provides the most targeted, appropriate option for managing KNN at this time when considering the predominant pathogens of interest, Streptococcus pneumoniae and H. influenza. Doxycycline therapy could be considered at this time as an alternative agent. However, it should be reserved for patients with a penicillin allergy that is documented and confirmed. Let's transition to the next question, please. And the next question reads, which of the adjunctive agents listed below may improve KNN's treatment outcome from her AE-COPD now? Is it A. magnesium sulfate 2 grams IV stat? Or B. prednisone 40 mg orally twice daily for 5 days? Or C. azithromycin 250 mg IV once daily for 5 days? Or is it D. methylprednisolone 80 mg IV twice daily for 3 days? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. prednisone 40 mg orally twice daily for 5 days. Based on the VA study findings, the GOLD guidelines recommend corticosteroids as they provide a benefit in AE-COPD by reducing the failure rates secondary to an exacerbation. 40 mg twice daily for 5 days is the appropriate dose and duration. Methylprednisolone for 3 days is inappropriate duration. And, since the oral route has similar efficacy, it would not be the preferred route. Azithromycin is not beneficial for this patient in the acute setting. And magnesium sulfate has not demonstrated any benefit in improving outcomes in patients with AE-COPD. And the next question reads: as the clinical pharmacist specialist in the ENT clinic, you review KNN's medical record and established that she has not yet received any pneumococcal vaccination. So my question to you is: which of the following would disqualify KNN from immunization with the 13-valent pneumococcal conjugate vaccine, also known as PCV13? Would it be A. anaphylaxis to latex and latex-containing products, or B. anaphylaxis to the hepatitis B vaccine, or C. recent upper respiratory infection with accompanying fever? Or would it be D. anaphylaxis to the diphtheria tetanus vaccine? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. anaphylaxis to the diphtheria tetanus vaccine. The only contraindication for receiving the PCV13 vaccine is anaphylaxis to the diphtheria tetanoid toxin. Recent infection and allergies to hepatitis B vaccine and latex are not contraindications to receiving the PCV13 vaccine. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video.